In this video, I will talk about the humerus and the elbow injuries. The learning objectives are to have an overview of basic anatomy and radiology of the humerus and elbow, etiology and management of humerus shaft fractures and elbow dislocation, basic anatomy and radiology of pediatric elbow, and a detailed note on common pediatric elbow injuries, the supracondylar fracture and the lateral condyle fracture of the humerus. First, the humerus shaft fracture. Just a quick recap of the basic anatomy of the humerus. A square accommodating the widest part of the upper end of the humerus defines its proximal segment, and similarly at the distal segment. The diaphysis is the part of the humerus in between these two segments. Now let's look at the muscular spaces around the posterior shoulder and the humerus. The quadrangular space is bounded superiorly by the teres minor muscle, inferiorly by the teres major, medially by the long head of triceps, and the lateral boundary is formed by the surgical neck of the humerus. Axillary nerve, accompanied by the posterior circumflex humeral vessels, pass through this space. The triangular space is inferior to this and is bounded superiorly by the teres major muscle, medially by the long head of triceps, and the upper part of the shaft of the humerus forms a lateral limit. The radial nerve, accompanied by the profunda brachii vessels, pass through this space and enter the radial groove on the posterior aspect of the shaft of the humerus. Radial groove is marked by the medial and lateral heads of the triceps muscle on either side, and the neurovascular bundle is separated from the bone by these muscle fibers. Here, we will see the course of the radial nerve. After passing through the radial groove, the nerve pierces the lateral intermuscular septa and subsequently enters the cubital fossa, where it divides into its superficial and deep posterior interosseous branches. The common etiologies of humerus shaft fractures are fall and road traffic accident. Here you can see the fracture line and the comminuted fragment. If you look at the deformity, the proximal fragment is abducted due to the pull of the deltoid, and in women due to the push by the breast tissue. The position of the distal fragment is variable. When the fracture happens in the mid-third distal third junction, the fracture fragment may lacerate the radial nerve, which is fixed by the lateral intermuscular septa. Such a fracture is termed Holston-Lewis fracture. Common complications of humerus shaft fractures include non-union, malunion, and radial nerve palsy. If the nerve palsy is associated with an open fracture, then a surgical exploration is essential. However, if it is associated with a closed injury and if it happens before a closed treatment, then it's likely that the nerve is injured by neuropraxia and hence a simple observation may be sufficient. However, if the nerve palsy develops after a closed treatment such as plaster application, then it is likely that the nerve is caught between the fracture fragments and hence a surgical exploration is mandatory. Such a phenomenon is called Holston-Lewis phenomenon. Coming to treatment, most humerus fractures can be treated non-operatively with simple plaster application, where either an immobilization cast in the form of a long arm slab or a U-slab is applied. Hanging cast is rarely used. It is a technique where the plaster is applied at or just distal to the fracture, such that the weight of the distal arm and the cast together is used to apply traction and align the fracture. To achieve this, the elbow should be left unsupported and hence the name hanging cast. Proximal humerus and shaft humerus fractures are sometimes treated by this method. Operative treatment is indicated in open fractures, non-unions, ipsilateral limb fractures, and radial nerve injury, especially the Holston-Lewis phenomenon described earlier. Standard treatment for humerus shaft fracture is open reduction and internal fixation with plates and screws. There is a very limited role of intramedullary nailing in humerus shaft fractures. Pediatric humerus shaft fractures heal well with simple immobilization with splints for a few weeks, and we can achieve a good healing. Now we will move on to our next section, elbow dislocation. Elbow has two joints. The ulnohumeral joint is a hinge joint and the radiocapitular joint is a pivot joint. The stability of these joints primarily come from the ulnohumeral articulation and by the way of the collateral ligaments. Radiocapitular articulation is the secondary stabilizer of the elbow joint. Posterior dislocation of the elbow, especially in the posterolateral direction, is the most common type. Here you can see the empty distal humerus and here the radial head is dislocated. Posteromedial direction is the next common type. Dislocation in other directions such as anterior, medial, lateral and divergent are rare. Apart from the obvious deformity, patients are in significant pain and clinically assessment of the neurovascular status is mandatory. Complications associated with elbow dislocation are the nerve injury such as the medial or ulnar nerve, vascular injury that is the brachial artery injury, bony injuries such as fractures of the coronoid process, the radial head and the medial epicondyle of the humerus. Ligament avulsion can lead to recurrent instability and excessive muscle and soft tissue injury can lead to heterotrophic ossification and stiffness. Elbow dislocations are treated by simple closed reduction under sedation or general anesthesia. Once the reduction is achieved, the joint is assessed for stability and immobilized in a back slab or in a sling depending on the stability. Check X-rays are done to confirm the reduction. Open reduction is rarely necessary. It is indicated in an unstable injury or when it's associated with a trapped fracture fragment. Open injuries or neurovascular injuries are other indications for an open reduction. Whether it is treated with an open or closed reduction, early mobilization, especially active mobilization, is the key to gain a good range of movement in the elbow. The next section is about the all-important pediatric elbow fractures. It is important to know the sequence of appearance of secondary ossification centers around the elbow and is as follows. The capitulum appears as first year, radial head third year, medial epicondyle fifth year, trochlea 7, olecranon 9 and the lateral epicondyle on the 11th year. Note the odd numbers of the appearance of these ossification centers. Using the first letters of each of these, an acronym CRITO is popularly used by the orthopedicians. It is important to note that the physeal injuries lead to progressive deformity, and the deformity is proportional to the growth left in the physis. Shortening is better remodeled than angulation and angulation better than rotation. Here is a quick look at the X-ray appearances of the secondary ossification centers. This is the capitulum, the radial head, the medial epicondyle, the trochlea, the olecranon, and the lateral epicondyle. Two radiological lines need to be remembered. Firstly, the anterior humeral line. It's a line drawn along the anterior cortex of the distal humerus in the lateral view, and it passes through the center of the capitulum. The head of the radius is always aligned with the capitulum. A line drawn along the head-neck axis passes through the center of the capitulum. Another important anatomical feature of the elbow is the carrying angle. It is the angle formed between the long axis of the arm and the long axis of the forearm in full extension and supination. It is higher in women than in men. And as the definition suggests, The carrying angle disappears when the elbow is flexed or if the forearm is pronated. Excessive carrying angle is termed cubitus valgus, and a reduced or a reversed carrying angle is called cubitus varus. Coming to the first important topic and a common pediatric elbow injury, the supracondylar fracture. It is the fracture of the distal humerus occurring just above the condyles. Here you can see the capitulum, the physeal line, and the distal humeral condyles are marked here. Supracondylar fracture passes above the condyles and close to the tip of the olecranon fossa, and the fracture line is marked here, and it's marked posteriorly and anteriorly here. The usual mechanism of injury is fall on an outstretched hand with hyperextended elbow. Metabolically active metaphyseal bone is thin, and this further predisposes it for supracondylar fractures. Displaced supracondylar fracture may kink or lacerate the brachial artery or injure the median nerve, especially its anterior interosseous branch. Flexion type of injuries can lead to ulnar nerve palsy. I'll talk about this in a little while. The most common type of supracondylar fracture is an extension type where the mechanism of injury is hyperextension of the elbow. Gartland has further classified it into type 1, which is an undisplaced fracture, type 2, where the posterior cortex is hitched and the anterior cortex is breached. In type 3, there is complete displacement of the fracture fragments. Flexion type supracondylar fracture is rare and may happen due to fall on the point of the elbow. Here are the radiological images of each of these type of extension type supracondylar fracture. When suspected, the management of supracondylar fracture includes pain relief, neurovascular assessment, immobilization in a splint or a back slab, and x-rays. Type 1 supracondylar fracture is treated with an above elbow plaster slab and follow up with check x-rays as necessary. Type 2 usually need a closed reduction and an above elbow plaster application. K-wire fixation may sometimes be necessary. Displaced supracondylar fractures, as in type 3, is treated by closed reduction and K-wire fixation. Closed reduction in supracondylar fracture is a simple procedure and is done under general anesthesia. Longitudinal alignment is corrected by traction and countertraction. Under image intensifier, the mediolateral displacement and the rotation are corrected. Finally, the elbow is flexed and a firm pressure is maintained over the distal humerus and the olecranon. Check x-rays are obtained and plaster or K-wiring is done. Complications associated with supracondylar fracture can be classified into immediate and delayed. Immediate complications are more serious and include vascular injury, where there may be a laceration or compression of the brachial artery, as mentioned earlier. Compartment syndrome can happen from excessive swelling, tight dressings, and plaster application, which can lead to workman's ischemic contracture, which I'll talk about it in a minute. Commonest nerve injury in extension type fracture is the anterior interosseous branch of the median nerve, and clinically is seen as a pointing index sign or inability to touch the tips of the thumb and the index finger. It is also called an OK sign. Ulnar nerve is more commonly injured in flexion type injuries and after a K-wire fixation. Delayed complications include cubitus varus deformity, hyperextension, and heterotrophic ossification. One of the feared complications of the supracondylar fracture is workman's ischemic contracture. It's a sequelae to ischemic injury of tissues enclosed in a tight fascial compartment. This happens usually in the flexor compartment of the forearm and results in ischemic necrosis of the soft tissues. Muscles undergo fibrotic contracture, attain a fixed length, and lose their function. Due to this, fixed contractures of the joint may develop. Ischemic damage of the nerves lead to loss of the sensory and motor functions, and the skin becomes dry and scaly. Nails show trophic changes, and the bone growth is stunted. Clinically, the forearm shows significant atrophy and the hand assumes the clawing position. Before the development of fixed joint contractures, Volkmann's sign can be elicited where the fingers can be extended when the wrist is flexed, but they assume flexion at IP joints when the wrist is extended. Prevention of VIC is early recognition, avoiding tight dressings and plasters. Note that disproportionate pain may be the only reliable sign of the compartment syndrome, and presence of an arterial pulse does not rule out a compartment syndrome. And if the compartment syndrome is suspected, urgent fasciotomy should be undertaken, and it's a clinical decision and not based on investigations. Once VIC is established, the outcome of any treatment is limited. Physiotherapy, muscle sliding procedures such as max page surgery, and if the deformity is significant, relative increase in the muscle length can be obtained by shortening the forearm bones or by proximal row carpectomy. Another complication associated with supracondylar fracture is malunion. Whereas malunion is a coronal plane deformity predisposed by rotational malalignment. Clinically, cubitus varus presents as gunstock deformity. It is more cosmetic than functional. This could be prevented by obtaining a proper reduction of the fracture and monitoring the reduced position till the fracture heals. Cubitus varus can be treated by osteotomy and realignment procedures. French osteotomy is commonly performed. In the sagittal plane, the distal fragment may remain hyperextended, leading to hyperextension deformity. This may coexist with the varus deformity. Here, the range of movement of the elbow is the same with more extension and compensatory reduction in flexion. This is because of the hyperextension of the distal fragment, which changes the overall orientation of the joint. The second common type of pediatric elbow fracture is the lateral condyle fracture. It is the fracture of the physis, and it could be either Salter-Harris type 4 or Salter-Harris type 2 fracture. I'll make a detailed presentation on Salter-Harris fractures in a later video. Note the capitulum here and the radial head here. The fracture line is shown in AP view and in the lateral view here. Significant soft tissue swelling is marked here. Sometimes it is the only clinical sign in an undisplaced lateral condyle fracture. An undisplaced lateral condyle fracture may be treated in a plaster, but it's carefully monitored with serial X-rays to look for any displacement. Some surgeons just prefer an in situ K-wire fixation. Displaced fractures are treated by closed or open reduction and internal fixation with K-wires as shown here. Note the significant rotation and displacement of the fracture fragment and the soft tissue swelling on the lateral side of the elbow. Complications associated with lateral condyle fracture is a favorite question for examiners. Non-union leads to serious long-term disability in the form of a cubitus valgus. Since lateral condyle fracture is a physeal injury, unlike cubitus varus of supracondylar fracture, the deformity here is progressive, and hence it may lead to tardy ulnar nerve palsy. Stiffness is another common complication, and overgrowth of the injured lateral condylar physis due to hyperemia may lead to cubitus varus deformity. Before we wrap up this video, a quick look at other common injuries around the elbow, sometimes covered in the NEET PG exams. If you have enjoyed this video, please like, share and subscribe and hit the bell icon for notifications. The radial head and neck fractures are usually treated non-operatively unless there is a significant displacement or excessive comminution, where it can either be fixed or could be replaced. A displaced olecranon fracture is treated by tension band wiring, where the tensile forces are converted into compressile forces and aid in early mobilization and fracture healing. A pulled elbow occurs in a child under 5 years when excessive longitudinal traction is applied on an extended elbow with pronated forearm. The radial head slips out of the annular ligament. It is an innocent problem, and it can be treated in the outpatient department by simply reversing the mechanism of injury, that is, by compression, supination, and flexion. This is the end of this video. Thank you for watching.